morning. I think we're live now. Yes, it says we're being live streamed from the State House. This is the Task Force on Affordable, Accessible Healthcare, and it's September 29th at a little after 10. So I think it probably makes sense for us as we get started to go around the table and do introductions again, particularly for those who may be listening and haven't tuned in before. So let's go around and let's acknowledge up front that we are in the State House, masks are required, and that we're all masked, but that we recognize that this provides some challenges in terms of hearing. So we're going to need to speak loudly. If you can't hear, please indicate to somebody. If they're not catching your attention, try to catch our attention, and we'll try to help with that. Also recognizing that for some of us, we were just before we came on acknowledging the challenge of glasses fogging up. So you'll see some of us taking glasses on and glasses off, trying to adjust as best we can. But with that, why don't we start by doing introductions, and then Senator Lyons and I have a few words. We'll move on to some other introductions of our consultants.
Great, thank you. So Representative Lori Houghton, I sit on the House Healthcare Committee and I serve Essex Junction.
Yep, Representative Ann Donahue from Northfield in Berlin, and I'm Healthcare Committee Vice Chair.
Representative Bill Lippert from Heinsberg, Vermont, and Chair of the House Healthcare Committee.
Good morning, everyone. Senator Ginny Lyons. I represent Chittenden County, and I chair the Senate Health and Welfare Committee, and with Bill co-chairing this task force.
I'm Rich Westman. I'm the senator from Illinois, and West on Health and Welfare, presently on natural resources in the morning, my afternoon.
Hello, Senator Keisha Rumsdale, Chittenden County. I serve on Senate Economic Development, Housing and General Affairs, and Senate Government Affairs.
I'd welcome our staff to also introduce themselves.
Sure. Jennifer Carvey, Deputy Chief Counsel in the Office of Legislative.
Will Langwell, Senior Fiscal Analyst with Joint Fiscal Office.
Why don't we hold on doing the introductions of our consultants and do that in a minute?
Sure, go right ahead. Why don't you give your comments, and then I'll
Okay.
get mine, and then we'll introduce
Okay.
Joshua.
Well, we are, as I was here this morning, I was found myself reflecting on the fact that we're getting together here as this task force on affordable and accessible healthcare, and recognizing in my own mind that this is not an event. This is more of a journey that we in Vermont have taken actually some significant steps over the years, but many of us believe we should and could and want to do more, make healthcare more affordable, more accessible to Vermonters. And I'll indulge myself and just say that part of what my own personal reflection this morning was today happens to be the anniversary for my spouse and myself. For those who, the significance of that for me uniquely is that the journey to being able to have an anniversary of marriage. It's our 12th year anniversary. It's actually in some ways a metaphor as well for what we need to do, how we get there. It requires us, it required having a vision, required a lot of concerted effort on everyone's part, not just the legislature. And it was a journey getting there, and it took a lot of work and a good deal of time. So for me, that's in some ways a metaphor today of where I see us. I'm wanting us to go and how and getting there. Turn it over to Ginny, and then we'll welcome our consultants to introduce them.
Terrific. Thank you all for being here, whether you're on Zoom or in the room. It's great to know how important this is, not just to the people sitting around this table, but to all the citizens of Vermont. The conversation around affordable, accessible healthcare has been going on for, I was going to say millennia, but maybe not quite that long. It's been going on for a long period of time. And as we dig deeply into the health system of care that we have, we find out that there are needs that people have to access the care they need at whatever stage of life they're in. So for me, as I look at the challenges of healthcare, it's assuring that people, regardless of their age or their health status, that they have access to the care and the supports that they need. So as we talk here around the table, I know that both the House and the Senate have a strong investment in identifying what we can do to improve our system of care, to improve access and affordability. And we will work hard to do that. We understand that there are some very glaring issues out there, and I include in that this workforce as one, and then some of the other timely issues that we hear about consistently in the news. But our job is really to get to the bottom of what is affordability, what is accessibility, who are the people who are in need of services at what stage of their lives, and how can we improve the system of care for those folks. There are a number of my constituents, and I think all of our constituents, who have very specific interests in what we might do. What we're going to work as carefully and as informed as we can to help improve the system of access and affordability. So reducing costs, that's very important. Increasing access, that's very important. And so I look forward to working with all the folks here at the table in front of us with our consultants. And we don't have a lot of time to do a lot of work. So we'll do what we can, and we'll do the best we can, and know that the work that we begin today will continue into the session. So again, thanks everyone. And I really look forward to this engagement with you and our consultants. So with that, why don't we introduce our consultant, Joshua Slen, who is the president of Health Systems Transformation. And Joshua, I'll let you introduce your colleagues and welcome to the team. We look forward to working with you. And I am smiling behind the mask.
I can see the smile in your eyes, Senator. So it's great to be here, to be back here. Many of you I've known for a long time. And for those who don't know me, in the room or on Zoom, I worked for Governors Dean and Douglas, and spent many hours, happy hours, mostly happy hours in this legislature working on policy and finance issues. And I ran the Medicaid program for 6 years. I was the principal author of the Global Commitment to Health in 2003 and 2004, and also worked on the Dale waiver, which has now been combined within the single 1115 in Vermont, but worked on that waiver as well. I stood up the Blueprint for Health here in Vermont. I hired Craig Jones with the Commissioner of Health at that time, and started that initiative. I also started the All-Payer Claims Database, wrote the law for that. In my time in the administration here, and happy to see that we've been able to move forward on all of those initiatives and to build upon those foundations. I came in after Dr. Dinosaur had been put into place. So I started in 1999 here in Vermont, and we were able to do the Green Mountain Care expansion for adults, under Governor Douglas. So I have not been around as long as some of you, but I have been around for a long time in Vermont and raised my family here and continue to live and love the Green Mountains. So thrilled to be back in the State House and to work with you. I'm going to do a brief introduction of health system transformation overall. And then I'm going to have Julie and Tim speak to their specific backgrounds. And I'm going to start by apologizing that Beth Waldman can't be with us today. She had an emergency in her family that she had to deal with. We will cover the pieces that she was going to speak to today. Hold her personal introduction to the next committee meeting when she can be here in person. So Health System Transformation Works is an organization that I founded 5 years ago and that works across the country with companies and with states and not-for-profits. All of the work we do, 100% of it, is focused on state healthcare issues. So whether we are working to help a company understand the state landscape or to help states accomplish what you're trying to accomplish here or many other things that states try to accomplish, we do operational as well as strategic pieces of work. This one is a strategic piece of work in our parlance. It is a passion of mine to help states be successful. So whether I'm working or we are working with not-for-profits or with for-profits, we're working to help states be successful overall. So we're going to help move this ball with you, and I'm really looking forward to doing that. I'm going to turn it to Julie and let her do a personal introduction, and then to Tim, who's on the video screen.
Thanks, Joshua.
Just, I think if you pull the mic toward you, it helps with the audio.
Okay, how's that? Good. Hi, everyone. Julie Trotter, I'm a principal consultant with Health System Transformation. I'm also a native Vermonter with 30 years-ish in health and human services. Started out working in community-based organizations here in Vermont with vulnerable populations. Went on to work for 3 different departments within the Agency of Human Services, including DEVA under Joshua's leadership. Then when I left state service, I was consultant for a number of states, in particular federal government, CMS, on some national projects. And I'm thrilled to be here. I just want to add my particular interest is in practice transformation, care coordination, social determinants of health or health-related social needs, however you want to talk about that, health equity, that sort of thing. So I'm pleased that that's part of your charge. And again, happy to be here.
Tim?
So, good morning. Happy to join you all virtually. I feel I should say, given the Vermont connection, that while I don't have a strict Vermont connection, I am Vermont adjacent. I should say, grew up in Connecticut and in New England, born and bred and educated. So hopefully that will give me a little bit of entree into the Vermont gestalt. So I am thrilled to be on this project and working with Joshua and his team. I'm the senior vice president for a company called Impact International, which is a health policy research consulting firm based here in Columbia, Maryland. Prior to joining Impact and as part of my role at Impact, have spent a career thinking about accessibility and affordability of healthcare. It's a passion of mine and something I pursued throughout my tenure in health policy. I have spent a lot of time at the federal level at the Centers for Medicare and Medicaid Services in a variety of executive roles, policy roles, I think that speak directly to some of the issues that we will all be discussing together over the next little while, having served in the marketplace, in society, sort of understanding and helping states bring up their state-based marketplaces. I worked very deeply and was a senior executive in Medicaid and CHIP and understand the particular issues around using Medicaid and CHIP to help states drive accessibility and affordability issues. And now in my current capacity, work very deeply with the Center for Medicare and Medicaid Innovation to help clients understand how to leverage the authorities and particular resources available at CMMI to help states achieve the ends they want to achieve with respect to access and affordability. So very excited to be on this engagement and look forward to working with you all.
Thank you. Before we go ahead, there is one housekeeping, sort of a housekeeping issue that I'd like to bring up, and that is that as we're working together, I think it's important that we understand the heavy workload that our legislative council and joint fiscal folks have right now. So be kind and gentle. But just a reminder to all of us.
And on that note, I'd also say a word of appreciation to both Nolan and Jennifer and other staff from the Joint Fiscal Office who went through the process of securing our consultants for us through an interview process and review process. And thank you for the work that it took, which was a considerable effort. And we're pleased that your work has resulted in having health system transformation folks with us today.
So the next, unless you have something else you wanted to add, no? We thought it would be extremely helpful to have a conversation and discussion around principles of affordability. And so Joshua, why don't we turn this over to you to get started? And I think we have a handout with a list of the principles of affordability.
Yeah, so the committee has two pieces of paper or two documents, PDF files in your email or on your screen. And one is titled Proposed Principles of Affordable Healthcare, and the other is the same but with accessible and inserted. So I randomly will just say, since it's the one I have pulled up, if we could start with the affordable principles. A couple of things. These are not the only things that could be put here. This is not wording that is asking you to adopt. We are just trying to have a conversation to start this exercise where we can hear from each of you and you can hear from each other what's most important as we think about the options which we're going to talk about later. And I would underscore, and I'll say it again when we start the options conversation, that everything we're putting in front of you or nothing that we're putting in front of you today is a recommendation. So we are at the point of putting ideas in front of us for the purpose of talking about them today and identifying the pathway forward. We have, as I understand it right now, 3 more meetings with you after this meeting, one each month in October, November, and December. And as we move from now until then, we will support this conversation that gets to recommendations for the December meeting, right? And so between now and then, there'll be this iterative process where we'll bring things to you, we'll take instruction from you and do research and produce analysis, and we will help that conversation move forward to identify the things that are most important to this group to do on the accessibility and affordability front. So as we dive into these proposed principles of affordable healthcare and dive into the principles of accessible healthcare, really what we're trying to do is to understand what the most important items are and to put a fine point on those things. The last thing I'll say here before we dive in to the conversation is that it doesn't go without saying, which is why I'm saying it, right? Which is that there are principles in law in Vermont, and that these are not those principles. They are not intended to reflect 100% of what's in those principles. they are not intended to substitute for those principles in any way. Those principles overlay everything that we're doing here. And these principles are intended to be a discussion of what's most important for this group to do now, right? So the be here now movement, right? Like, so we're going to try and be here now to do what we need to do today, where Vermont is today, to move things forward. And so I would encourage us not to get hung up on that everything is in this, or, you know, so let's just make sure that the things that are important for you today so that we can be directed in our work are here. And that's really what I would ask as part of this conversation. In order to move it, what I'd like to do is to just have you take a moment to read through the principles of affordable healthcare here. There's a few bullets. And then if we could have some discussion about what's important on here, what's missing from here in that way.
So I think no one just wanted to get it on. It's not up on.
Yes.
I'm just gonna say, Charlene is posting all of these up on our webpage. So
Okay.
everyone who is listening in can access the information on the Task Force for Affordable Accessible Healthcare webpage.
And just as I have a very technical question. Can we remove this to drink that?
Yes.
Okay, great.
It's an important question.
It's tempting me. I want to know if I could do that.
Pause only.
Yeah, I've already done it already. It's a challenge to manage all the various things to do while we're being masked and trying to keep everyone safe.
Can I say something? Are we going to be getting our discussion?
Oh, please.
I want to go to the fourth bullet. And the fourth bullet is one that I hear a great deal about, particularly for those who have chronic needs or high prescription drug costs, or run into an emergency situation where the cost of care exceeds their ability to pay and goes beyond the coverage that they have. For me, it's linked in with the percent of income that we have, and I'm trying to figure out how does one determine what is the maximum percent of income per household that one should be paying for healthcare? Then when someone runs into the acute cost, extraordinary cost, that's a good word for it. How do we deal with that? It's just a very blanket statement. Question. I mean, those two bullets, all the bullets are important. I wouldn't leave anyone out, but it lends itself to the second bullet as well, with the out-of-pocket costs and so on. But bottom line is, how can we ensure that people's income at any stage and any condition meets the needs that they have? What data do we have that helps us move ahead?
Yeah, so I think when we start to score options, one of the things that we'll be able to look at is for different, so let me step back. One of the things that we want to think about as part of all of this is for who, for what, or for whom, for what. So when we think of a few things that came up, Senator Lyons, in what you said, is there are emergency situations, there are extraordinary situations, and there are normal day-to-day situations. All of those instances, you could, as an individual household be in a position where you're making decisions, either small decisions to buy the smaller half gallon of milk instead of the gallon, and hope you have enough for another half gallon later, or big sort of decisions around do we go to the hospital with this acute event or not? My perspective is that those accrete. So the half gallons of milk accrete. They pile on top of each other and become emergency in a lot of situations. And those big decisions not to go to the hospital are things that also could be very important to consider as far as are there policies that could be put in place that would reduce people making the wrong decision there, right? Like not go to the hospital. The percent of income conversation is not irrelevant to either of those, right? So there's a long way for me to get around to, like, I believe that the percent of income conversation is an important conversation, and there are other states that have had it decades ago, in fact, some of them. And there are states that are moving on affordability indexes today. And so as part of our research, we can put in front of you for the next meeting some of those, what other states are doing and what those ranges are. Vermont has done some work in this area as well, specifically. So the general range is somewhere between 5 and 15%. Okay, so I'm outside of range on both of those of household income. Sort of what if you're spending more than that, it's unaffordable. And we can and we will put a bunch of those examples on the table. What's right for people of different income levels is another question. So it's not. Some states are working on progressive ranges there, right? So that at a higher income level, a higher percent of income could be spent. That conversation, of course, doesn't, it helps us to think about affordability, but it doesn't allow us to implement a specific initiative, right? So I would also ask us, as we think about affordability and accessibility, to think about the high level policy constructs that help this body think and decide things, and the on the ground implementation things, which is, are we going to lower out-of-pocket premiums, out-of-pocket expenses, or are we going to subsidize in premiums, or do a reinsurance, or what are we going to do, and how will it affect buying that half gallon of milk, or that decision to go or not to go to the emergency room?
And then add to that the inflationary principle behind the half gallon milk. And the cost of the milk is going up at a rate higher than the rate of wage inflation or ability to pay. So how do we, I think in the information you sent us, there's at least one state that has put a cap on, for example, hospital growth. And I don't know if any states have put caps on insurance rates growth and medical inflation itself. Do we have any of that data?
Yeah, so we do have information. Rhode Island, for example, has for a long time, I forget how many years now, but they've capped the growth of insurance rates at 1% over inflation. There's a lot of detail under the hood in those decisions. What inflation rate and measured at what point in time, and all of those things, which really matter from it being meaningful to being not meaningful at all. And so figuring out how to do that and whether that is something you want to do in Vermont, is another thing. Certainly Maryland has had global budgeting for their hospitals for a very long time. And Pennsylvania has a hospital budgeting process as well. And so the ability to manage spend. Vermont certainly has structures in place that could be utilized to or could be amended to put caps on growth rates. So the waiver, the all payer waiver has a 3.5% growth target, right? There's no teeth to that target today for overall health care expenditures in Vermont. But certainly one of the things this group could consider is whether there should be caps on components or on the overall growth rate and how you would actually manage to that. In New York State, there's a growth target for Medicaid, and they have a reform commission that is continually now making cuts to programs and adjusting downward on utilization in order to try and stay within the growth target. So creating a mechanism like that and a structure that functions in that way has repercussions to downstream repercussions to potentially to accessibility at affordability at the expense of accessibility in some cases.
So I think it might be helpful to have folks sitting at the table just comment or offer your questions. And I'm just trying to throw a couple of the bullets out there because I know that they are pressing issues, but the conversation. Good.
So just a comment based on what the conversation has been, I'd be curious to see with those states that have had a percentage, what's affordable actually named, the percentage of income, especially those that have had it for a long time, you said, what the effect has actually been on affordability of healthcare, because I was drawn to that idea because when you think about housing, you always know 30% of your income or less should be spent on housing. But has that really translated into effective policies that are making sure that people only pay 30% or less? And I'm not sure it does. So I'd be curious to see what the effect has actually been. My other thought in just looking at these is it is all cost containment rather than understanding what is driving the cost and fixing that. And we can cap and see what happens, and we can cap again and cap again. But if we're not determining what the underlying costs are that are driving the increase in healthcare costs, where does it really leave us in the long run? Go ahead.
Go ahead, Representative.
No, I was just going to say, I think that the fourth one on the broadest level is kind of really captures the broad concept, and then that directly ties to both what Lori is saying. In order to kind of assess or look at that, you have to include how the cost being driven. And the two before, I think, are really tools towards identifying how to achieve a broad principle like that. I think the second one's really important because we often look at out-of-pocket expenses without combining it with, well, does your employer pay, 60% or 90% premium? But getting that number, is incredibly difficult. But if it's only out of pocket, it's really difficult also to tie it to income because it's such a broad range depending on your needs in a particular year. If you focus only on premium, you totally lose the element of, I've paid for this, so I'm entitled to use it whenever I feel I need to use it perspective. So I guess I'm just saying, I think the broad one is important, and then all of the others become really, really lots of things under them. because it's tied to whenever we tie to income, we run right into all of the changeability inherent in, moving from one job to another. So you might have several changes in, is it affordable to you, given those circumstances? So it makes it incredibly hard to identify who is most disadvantaged in reaching that critical overall principle, I guess.
And Representative Donahue, you point out something that perhaps not everybody, we all might understand, but we don't always remember, which is that when we're talking about those somebody's change. So an example I like to use is that when we talk about enrollment in Blue Cross Blue Shield or Medicaid or whatever insurer, those people are not static. And in fact, the movement is much more dramatic than many people realize. So the number nationally for Medicaid is around 40% of the people come on and off Medicaid regularly, meaning at least once a year. And so that's an incredible amount of churn. And those people are moving to uninsured, and they're also moving to insured. So that's just something to keep in mind, that we're not talking about the same people at any point in time when we look at the data.
No, but in principle, we're also talking about people who get off Medicaid, would like to be off Medicaid, but their wages don't support the insurance that is waiting for them when they do get off, which is a big cliff issue, a big, something that I think becomes a practical issue. Senator Westman or Senator Hinsdale?
Okay. So 2, 4, and 5 stuck out to me as, first of all, I think the fewer the better is my general. And I think those are sufficiently broad, but also measurable and actionable and feel sort of cohesively important. You were mentioning, Josh, the idea of decisions like going to the hospital. What's on my mind, and I think the mind of a lot of constituents, is decisions like getting married, having a child, switching jobs, starting a business, bringing someone into the household who needs care. All of these life decisions seem so tied up in whether or not it becomes affordable to maintain care. And I don't really know how to measure that, but it feels related to, households obtaining necessary healthcare. But I feel like that sentence, or the holistic picture of a person, is missing the kind of societal goods that come with being able to not have your health insurance tied to employment or life decisions.
Yeah, that's a great point. And as you said it, I was thinking that there's got to be I think we should work on a couple of words that can reflect, that can support those decisions that people make that change their family size, or constitution of what's in the family, and might impact or would impact the cost of insurance, and decisions that group, that household would be making. One question I have for the group is, we have purposefully said per household here, and I would like to just have a discussion or get direction on, is that the right focus for us as far as accessibility, or as far as affordability and accessibility? Should we be focusing on households? What's affordable to households? What's accessible to households?
So follow-up question just to that comment on households. I think my response back to you would be, well, what does, at the federal level, what policies are in place today that affects whether we are looking at a household or an individual or a family. I mean, I can't think of anything particular, but I feel like we're always grappling in our committee with, well, if we do this, it might be at the household level or the family level and individual. So is there a difference, a measurable difference that would impact what we want to include?
So we can come back to you with, the differences from, you know, in different areas that, yes, there's differences in different areas for Section 8 housing or for foster care or for education, you know, 4E. There's differences in those, how definitions are utilized and applied across different federal programs and state programs. What I was inexact in my ask. What I was really trying to get at is not whether we're talking about Lori and Josh, right? But whether we're talking about the consumers in Vermont, the Vermont residents versus the Vermont residents and also the small businesses, the large businesses, the state of Vermont, the federal government as a partner, because focusing on the residents of Vermont and using household and clarifying what that means when we're up as far as family and individual is what our assumption is right now, and not focusing the work on affordability and accessibility on those other important but not the same.
Thank you for that clarification.
I frankly need to have you clarify it further because I didn't follow that.
Sure.
In the same, when I was on the same track of where we measure sometimes affordability in terms of household versus family, or individual, et cetera. So can you say again what your thinking was?
Yeah, sure. I can try and say it again. I mean, I can say it again. Hopefully I can try and say it more clearly. So
well, it's a matter of hearing it again, that's all.
So the differentiation here that I'm making in how we think about affordability is something that we do, a policy that we enact could be affordable, make things more affordable for healthcare, for families, for residents in Vermont, for the humans that are consuming, and more expensive for our federal partner, or more expensive for our state and our federal partner. And as a result, could make it more expensive from a tax perspective on a corporation, or from a policy perspective on a small employer. And those effects of what we do, we can point out as part of the process, right? But as we prioritize and think about, I'm thinking ahead to when we're going to be force ranking things to get to the, the priorities that are going to move forward. If we're going to be focused on that resident cost, that household cost, and not on the cost of the other payers and corporations.
Well, thank you for restating that. It's helpful to me. I was hearing it this time, and I would just suggest that they're not mutually exclusive questions. I think they're both and that it seems, for me, it does seem like potentially a key measure is maximum percent of income per household, which is a building block perhaps, and then looking at, as you're looking at other measures as well, whether it's state and federal government, and has to do with tools, what the legislature and the executive branch are willing to bring to bear, and what our federal partners are able to offer, for et cetera. So I think it's a both and. At this point, just say we need to understand both, but I wouldn't want to substitute one instead of the other. at least at this point in our discussion.
And I mean, part of that ties back to looking at affordability through the cost and then avoids that shift. And you also, I think your last two bullets touch on those, not just shifting costs, if we shift them to to employers, but ultimately, it's only people who pay for anything, right? So, you know, we can shift it to the state, which means the tax, okay, which people are still going to pay, or to the businesses who then raise the cost of products and so forth. So it's how that money is funneled rather than ultimately, because if we're looking at, as Bill was saying, we're looking at affordability, what percentage should go for healthcare is going to affect what you're paying in taxes too. If your tax rate is higher because the state's spending more money, then that's going to affect what's affordable for your healthcare in terms of what percentages are left. So I think they're so interconnected.
Am I gonna, sorry.
The household is the basis, but the impact on that household has to consider all of the impacts on other parts of the system.
And sorry, I'm really fast.
No, go ahead.
I think there's still another component to that is even at the household level, it depends where you're buying your health insurance through. That affects what's going to happen and what we can affect. So even if we say affordability at the household level, okay, but that's not necessarily going to touch all Vermonters because there are different ways people are getting their health insurance, ERISA versus Medicaid versus, you know, some other method that may affect how we can help those groups. So, you know, I think it's much broader than just, you know, household, federal, state, corporation.
I think Senator Westman had something.
Somewhat in this. We have two sheets. We're talking about accessibility and we're talking about affordability and the principles to each separately, which a little bit distresses me. And I'm gonna give an example of that. Monday night, I'm at my hospital board meeting. And we really are having a workforce crisis within our hospitals across the state, and particularly in emergency. We, in the last 2 weeks, been called at least once reported St. Albans, the Northwest, couldn't serve people that came to their door because of staff issues. And they called Burlington and the medical center down. We couldn't take them because we were full. They didn't know what to do. I don't know what the resolution is there. We are now facing tremendous increased costs within our hospital budget with traveling nurses. And the workforce around that and those traveling nurses in that segment of the budget is now backing up into our overall costs. So to have the conversation where I have a set of principles that are affordability over here and accessibility over here, I know where I'd like to go, and I think it's all important to talk about household income and that. They have to touch. And I'm struggling a little bit with this because, you know, whether it's my home health agency, whether it's my nursing home, whether it's my hospital, or whether it's my doctor's offices, the competition for workforce now is becoming overwhelming for our providers. And it relates to their salaries.
So I think what you've hit on is one of the really difficult areas that we have struggled with legislatively. And I know that our providers are struggling. But on the other hand, if you look at it, I don't want to move us away from affordability, but if we were to look at, let's stick with affordability. If we were to look at affordable primary care and preventive care as primary, then that may be I know it's a longer term solution, but it may be a way to obviate the need for the increased workforce demands, and particularly we're looking at those now with COVID. But I think you're absolutely right, Senator Westman. Workforce is a huge issue. But as we go through some of the elements of the affordability principles, we might identify ways that mitigate or sort of push off the workforce discussion. I don't want to push it off too far, but yeah.
Just my question is, in these overall arching principles, where does that fit? What you just talked about.
Through access, I would think, and affordability, because
So it is access.
So, and if as I said, if we focus a little bit on what's happening in the rural parts of our state where primary care folks are leaving, then focusing on bringing those primary care people in and providing primary care access affordably might help to mitigate the workforce issue. So I think workforce becomes a very targeted discussion, whether it's hospitals or FQHCs or community services, whatever it is.
Mental health,
Yeah. Mental health.
where there's acute crisis. Can I just throw a thought that, sometimes we can learn, what can we learn from other things that we've taken on? And your committee, Senator Lyons, more than the healthcare committee, not the healthcare committee, but the Human Services Committee, has wrestled with the issue of childcare affordability and also workforce issues. And I'm thinking to some of what has been set as aspirational goals for maximum household expenditure and efforts to address the challenging issues of workforce in that arena as well. And so I just, not to take us off on a different tangent, but to just put on the table that I would be interested to know if there's anything that we can learn from the process of trying to wrestle with that issue, where both issues are, both affordability and workforce have been very real and acute as another piece of the larger affordability issue generally.
I just step aside for a second, and I want to let people know that they're having problems posting these documents. People are wondering why they're not posted. We're having trouble with the IT on it. So at the request of Representative Houghton, we're posting it on the screen that people at home can see it as well.
Okay,
Perfect. Thank you.
thank you.
Not IT, but thank you.
They're working on
It's an
it.
answer.
Not to, I don't think this is on any disagreement with my.
Keisha, make sure you talk.
Oh, okay.
Sorry, Senator Hinsdale.
Yep.
Yep.
Nope. But I do want to kind of put a marker in the ground for this, for measuring it from the perspective of a household, because I think we have a common measurement to say, we keep saying this kind of Vermonter and that kind of Vermonter, and I care about the workforce, I care about, but when we look at a household, ultimately, I feel like that's an important way to measure equity. And some of these ideas, if we go down that road, it may become more inequitable. I do want to kind of posit that around the universal primary care idea. It feels like if you give people a little bit of access, you don't treat the whole household, you don't treat the whole person, you don't treat the whole patient. I think we run into inequities there. And I would rather we use these principles with one unit of measurement or perspective in mind and really think, is this creating more equity or is it exacerbating for other problems down the road? So I think we also have to use these principles for what are we trying not to do as well, and our strategies and ideas. I think it's important that we start with principles because our strategies and ideas could get us a field of, you know, household equity, access to affordable healthcare, you know, the kind of unit of measurement that I think is really critical. Being on a hospital board, I get the workforce issues, this traveling nurses, the staffing shortages. It all has to come back to one unit of measurement that we feel like we're moving the needle around, which I think is the Vermonters asking us for affordable, accessible.
So there's one vote per household. No,
For
but I
one
think it's a
unit.
very compelling argument that you make. Yeah, great.
I would say, I don't disagree that I believe the component of this, but I think someplace they both go back to the principle. But it's important that we not stress the individuals. With the crisis that we've got, where's the overlap to how do we incorporate that into these overall?
Does the per household metric,
We're not making decisions.
no,
today.
no, we're not.
So
I mean, does
just want to
anyone
caution us
have
from-
another perspective, I guess? At this point, okay. No, there's no decision being made.
One comment, if it's appropriate, that I would make here on Senator Westman, you comment around workforce, and in particular, how affordability and accessibility both need to be thought of together. So just from a process perspective, I would say that we're talking about affordability and we're going to talk about accessibility. And underlying all of these things, which is not in the title of the group, is quality. And often, always, when I talk about moving healthcare, we talk about there's three different things that we want to do, right? We want to make it affordable, we want to make it accessible, and we want to improve quality outcomes. And when we're doing those things, as everyone here knows, we also often talk about how challenging it is to do all three at once. And that when we make things better, when we can improve outcomes and spend lots of money and restrict accessibility, we can improve accessibility and quality and spend money. It's hard to do those two things aggressively and save money at the same time. The qualifier to that are things like when we move the long-term services and support systems out of expensive nursing home beds and close nursing homes, as we have over decades here in Vermont, right? And move people into the community and serve them on average for less. Some actually cost more now than they would cost in a facility. But that's an exception to our rule, and think of how long it took to do that, right? So it's hard to move systems of care in a quality and accessibility and consumer-friendly fashion. And I know everyone here knows that. So, you know, for everyone listening as well, that those things take some effort. And so one of the things, as we talk about these principles here, to consider is specifically when we get into the options, what are we going to do to help move the pieces forward, recognizing that affordability, accessibility, and quality, they're all in the mix when we decide on where we're going to go. And your consultants are going to keep that in mind in our scoring rubrics, and we'll be able to we're going to create some scoring for you on these options as we move forward here that'll take into account some real specific data that's available, and also some areas where specific data isn't available. And so I would mention both of those things as well.
So just being aware of time. I think we should take a quick break right now and then come back to talk about accessibility. So just a 5-minute break, a little stretching break, a little bathroom break, and then come right back and be back here before 1/4 after would be helpful.